You ready, Ravana? Okay, so first and foremost, good morning to everybody, and thank you so much for joining us for today's session. I'm actually very, very excited to introduce our next guest, and we do have Ravana Babalal, who is a medical ethicist in the medical profession. Ravana is a specialist bioethicist, medical legal forensic medicine practitioner, and a doctoral candidate centering around forensic medicine. So in the past 15 years as a practitioner and as the director of her own private practice, she's assisted physicians and healthcare by providing guidance and advising on their day-to-day complexities in the medical practices and institutions. She also assists with many obtuse medical issues and has authored the paper on physician-assisted suicide. She's graced very prominent public platforms and medical institutions by delivering academic briefings via webinars to hospitals on medical legal ethics content, and she has also been appointed to the disciplinary bodies of the KZN Provincial Legal Council practice. Her extensive involvement in the COVID-19 pandemic has been acknowledged, and she has actually been received the Woman of Wonder Award for 2022, and she does feature in the top 50 influential leaders in business in South Africa. Ravana, thank you for joining us. I know you have a very hectic schedule, so we're so happy to have you with us today.
Thank you, Nadia. It's such a pleasure to be on the i2 platform, and especially on a day like today. So before we kick off, I just want to share a little story with everyone this morning, being the Day of Love. So Nadia is aware that my webinar was scheduled for last Tuesday, which was the 8th of February. And due to calendar constraints, it was moved over to today. So in that respect, I was thinking about it, and, coming from the healthcare background, I said, but why was it today on the Day of Love? And when I reflected on it, being someone that's so big into positive energy and the law of attraction, I just figured that when in healthcare, love is such a dominant factor. So when we go in and we see a critically ill patient, and irrespective of how optimal a treatment is, there's two things that they hold on to, which is love and hope. So therefore, with that being said, on the Day of Love, I would just like to say that love is the greatest medicine, love is the greatest healer, and happy Valentine's Day to all. Thank you.
Thank you for that, Ravana. And I think the best and the most appropriate question that we should be kicking off is with, what is a medical ethicist?
Sure. So with regards to the medical ethicists, they are gatekeepers of the domain of medicine who direct the integrity of the medical profession by ensuring compliance of all role players in healthcare, to ensure that the moral fiber and nobility of the practice of medicine is associated with, is incumbently honored, in view of the fact that medicine and medical ethics are inextricable. So medical ethics is one of many disciplines of my meet here, yet when amalgamated with my subspecialties, which is medical legal practice and forensic medicine, it culminates into a stupendous footprint in healthcare, as it is a nonpartisan role where scrupulous decision-making is advanced in the interest of all parties, in instances where medical professionals stand at crossroads in their daily practice on grounds of legality and righteousness. Thank you, Nadia.
Yeah. Well, that's very interesting. At least today I finally got to find out what exactly is a medical ethicist. And then my next question that actually follows on is, what exactly do you do as the ethicist?
So in general, medical ethicists such as myself, we distinctly pontificate on morals and principles on the subject of practice of medicine, intriguing ideas of history, philosophy, theology, sociology, aiming to make judgments about treatment possibilities, medical research, conflict of rights of medical practitioners versus the patient, medical dilemmas, and so forth. So the medical ethicist, I would say first and foremost, we basically address the individual patient well-being. So the medical ethicist's assertion of duties will keep either doctors, patients, their legal guardians from reckless disregard of others' interests or selfish exploitation of the system for their own benefit. The medical ethicist ensures that both the doctor and the patient or the patient's legal guardian fulfills their responsibilities in making effective contributions to the doctor-patient partnership, which is very important, and each taking seriously the interest of the other. So for the sake of the flourishing of the profession and its instrumental effectiveness in upholding the patient's best interests. So medical ethics, basically, the ethicists promote privacy, confidentiality, truthfulness, health, well-being, respect, dignity, and accountability in the medical profession. So this sphere of the profession commands one to be very liberalistic, as medical ethicists wield a prodigious role in reigning as a median in abetting patients, medical professionals, and healthcare institutions to make virtuous decisions when in predicaments, as we are cognizant that erratically judicious decision-making miscarries when subject to stress, where healthcare professionals may not think rationally and make perplexed judgments and decisions in their daily practices. So a lot of people know that medical ethics, people think like, what is the philosophy in it? So yes, we do draw a lot on the philosophy, which is jurisprudence, where we apply principles when making decisions, such as principles of autonomy, which basically means that the patient has a right to make decisions in terms of their own health care. Then we have a principle of non-maleficence, which is where everyone has an obligation to not inflict harm on others. So that's the maxim of do no harm, which is not just in healthcare, but it applies across all ethics. We also apply the principle of beneficence, which is where physicians have to have a duty to make a positive contribution in the lives of their patients and remove harm in patients' way. And then we have the principle of justice, which is where we do a balancing out of ethics to see the ethical aspects are in compliance with the law, patients' rights, and if it's fair and balanced. So the synthesis of medicine and law has created substantial appeal and inflated demand for medical ethicists, considering the era that we are existing in. And I'm sure everyone can relate to the Dr. Google, where every patient now knows their diagnosis, they know their treatment even before they can see a doctor. So that creates a bit of a dilemma in medical practice. So we call this the era of quacks. That is, everyone wears the white coat with no medical degree. So in that sense, this classifies our services as extremely crucial and paramount by virtue of the fact that the presence of medical ethicists reduce the plights of doctors and other healthcare workers, patients, and medical institutions, colloquially creating consonance in the doctor-patient relationship. So with ethicists having such comprehensive medical erudition via the priming of proficient medical minds expands your horizon and enables one to practice with sagacity and efficacy in the profession. Thank you.
So I won't lie, Ravana, I've actually on a few good occasions been guilty of being that Google doctor that you've just spoken of. So take us, I guess so, and take us through what is a day in the life of Ravana, the ethicist. What exactly does your day encompass?
Certainly. Okay, so get ready for this one. This is a bit of a roller coaster. So every day of our lives is unanticipated. In actuality, there's no vocations or predicaments are ever precisely theorized. We basically live, as I said, roller coaster sort of lives. So in our basic day, the medical ethicist lifestyle becomes accustomed to 24/7 critical thinking, analytics to problem solving, where your mind is always active. Our days are described as, in words, supersonic, enthralling, stimulating, vast insolence, where you actually get accustomed to erratic sleep patterns and being multifunctional due to the demand for such expertise. So in a nutshell, it's like a daily gym workout of both the mind and body. Therefore, one has to have a sense of magnetism towards the profession as it becomes a part of your identity. So the life of a medical ethicist is never your typical 8 a.m. to 5 p.m. job. This type of profession is one that gives off fair amounts of adrenaline. Coffee becomes your life coach. And most importantly, the daily roller coaster of constant mind stimulation, which are amazing as your days are never monotonous. So over a decennium as a specialist practitioner, I can honestly say that I get surprised every day of my life. And I've actually come to realize that I do love surprises, as it converts into good stress and it keeps me active. It helps me to make a difference by ensuring that ethics and righteous decisions and resolutions are reached on a quotidian basis in the interest of all. Therefore, it helps me to identify my strength, not just as a human being, but more especially as a female. So that means the ability to manage copious amounts of stress with equanimity by remaining poised in the most abstruse scenarios when dealing with problems to ensure efficacious corollaries based on the highest standards. It's really exhilarating to listen to many predominant males that we shield on a daily basis in the profession, where they say to us on a recurring basis that the future is female. And what is my response to that? As a woman can do anything that a man can do, but even better in 5-inch heels. So no offense to all the males out there. So basically my mornings commence from approximately 3 a.m., believe it or not, emanating from medical calamities that necessitate my assistance. So provided that there is a doctor out there that is active and in a predicament, indicates that I need to be conscious to support the anxious medic. Fortunately for the world of technology that alleviates the concern of me traveling in twilight to every emergency site. So nevertheless, if the medical practitioner is in urgent need of my attention at erratic hours, then I would need to be there to assist. This means that I am the distinguished delinquent of all gym trainers. Discipline commands that breakfast is the most intrinsic meal of the day and must be fulfilled by 8 a.m. I really hope that there are no gym instructors frowning upon me on this platform. So conveniently, I do ensure that I'm supplemented with my black coffee and overnight oats with the sentiment that it is not only detoxifying my liver, but also catalyzing the adrenaline to steward myself of the day ahead. Subsequently, the multi-utility commences from having a phone fused to your ear, comparable to an organ transplant, to reporting to omnifarious medical practitioners or hospitals, either in critical care crises, or to extricate a distressed doctor from liability in respect of an antagonized patient or family accordingly. It's certainly not your posterior to the desk categorization of profession. Expeditiously, I may confer guidance to a trained practitioner over the phone while simultaneously assisting in a palliation session, to additionally accommodating a briefing from a legal firm who are approaching gridlock with their extant medical legal matters, which warrants expert consultancy from myself, due to the fact that I possess intrinsic combination of medical, bioethics, and medical legal knowledge. Therefore, resolutions are facile for me. Amidst these activities, time has to be assigned for the white collar job via your laptop. So that is where I go to rest in that sense. And I examine instructions of legal entities that brief me to enjoin them on their medical legal matters as a connoisseur consultant, to conceive extenuations for healthcare practitioners in respect of complaints to the Health Professionals Council of South Africa. So inevitably, I end my day by burning the midnight oil in order to prepare for the challenges ahead. I do acknowledge that atrexia, which means mental balance, is pivotal to every human being. Therefore, my equilibrium is maintained by a phenomenal fellowship, which is healthy. As being a public figure, conservation of social interaction is paramount to our growth and psychological vitality. So a day in the life of a medical ethicist is one that I anticipate with enthusiasm, notwithstanding the strenuous status quo, insomnolence, and difficulties to consume meals punctually, as my work in COVID-19 has taught me to be appreciative of each day, which permits us to experience and act on such exposures by making a profound impact in the lives of others, by ascertaining that we complete each day by aspiring to uphold strong ethical principles with the foresight to propel for the greater good in healthcare. Thank you.
Thank you for that, Ravana, and thank you for sharing what your day actually looks like. From my point of view, it sounds very hectic. You live on coffee and you deal with some rather very complex situations. So I'm going to hand over to you right now. And what we would love for you to do is actually take us through those scenarios that you have faced, over the years, and actually basically give us an indication of which are those scenarios that actually requires the ethical decision making and the outcomes. So over to you, Ravana.
Thank you so much. So in respect of my ethical scenarios, I'm just going to cover a few scenarios that I've basically dealt with in private practice. And I've been I've touched on these scenarios specifically as I feel that some of them are quite common and it is very interesting. And these are things that people don't just have to apply in terms of whether you're an ethicist, it can be applied in terms of the daily life of an individual. You know, it's good to be knowledgeable about certain things. So with respect to my first scenario, I speak of a 48-year-old patient that was basically admitted into hospital with a myocardial infarction, which means that's a heart attack. So the patient presents into trauma, the patient is hypoxic, and the patient is declared PVS, which is vegetative, after a neurological assessment. The patient also had multiple comorbidities, a below left knee amputation due to gangrene, and in a nutshell, the patient was dying. And amidst all of this, the patient did not have a DNR. So the doctors felt that it was necessary to have a DNR in place for this kind of a patient. And they obviously spoke to the spouse about it because the spouse becomes, the next of kin becomes a consenting individual for such a patient. So in this instance, upon speaking to the spouse was quite happy to go ahead and do the DNR with the medical team, but the spouse did not want to follow the informed consent process. Now, in this sense, there's certain procedures that need to be put into place, and it is very important to be compliant in that sense from both a legal and an ethical perspective. So the doctors were in a conundrum in this respect, and they instructed us as medical ethicists to come in to assist them in their decision making. So what did we do? So we basically advised doctors that when CPR is futile, the physician in charge of the patient's care must order that the patient will not be resuscitated, even against the wishes of the patient or his or her representatives, relatives, or friends. There is no legal duty on doctors in healthcare to provide futile treatment to patients, even if it is requested for by the patient or their loved ones. It is crucial to be cognizant of the fact that in terms of legalities, a medical practitioner does not require permission of the next of kin to adjure a DNR if CPR is futile. So we inform the medical practitioner in terms of the HPCSA guidelines that the DNR should only be made if consulted with the patient, and if the patient is incapacitated, then they have to fulfill the informed consent process via counseling of the patient's family, or the closest next of kin, unless the patient has clearly stipulated beforehand that he or she does not want any family member to be counseled. So in that respect, doctors have to be compliant with that. Then we went on to stress the importance of the informed consent procedure, where we directed the doctor to comply with the HPCSA guidelines by refusing to make such an order as per the spouse's instructions, until the spouse representing the incapacitated patient was properly consulted and counseled in terms of the aforesaid protocols, which must be effectuated in terms of the HPCSA guidelines prior to ratifying a DNR. It is also interesting to state that when CPR is hopeless and the patient or the patient's representatives or loved ones, they must also be given a further option of transferring that patient to another facility, which we all know as a step-down facility. And if this option is refused and the healthcare team considers treatment to be futile, provided that it is confirmed by an independent medical practitioner, the treatment may be withheld or withdrawn, and that is completely legal. Right. And the patient and everyone else involved should, however, be told that all forms of treatment and care will remain unaffected by the DNR order. Therefore, we ensured compliance with the aforesaid rules by guiding the doctors and providing the spouse with various propositions in respect of the patient, such as we gave them the option of a DNR, we gave them the option of palliative care, admission to a step-down facility, upon adjudging the patient's prognosis as severely grave, with the consensus of the medical team. So based on the guidelines of the HPCSA, we ensured that the doctors follow the conformity to pertinent consulting and counseling processes which we presided in. And we ensure that concord was reached in respect of the DNR order between the medical team and the patient's spouse representing the patient. So hence we were successful in achieving completion of the DNR, which was ultimately in the best interest of the patient, pertaining to his dignity. Therefore, this was just and equitable in respect of all parties from both a medical, legal, as well as an ethical perspective. So going on to another scenario. So this scenario, I'm sure every person can relate to. I'm sure there's some family member that's been through this. So in this instance, we had seen a 52-year-old patient who was admitted into hospital with a stroke. The patient was comatose. Therefore, once again, the consenting party on behalf of the incapacitated patient was the spouse. So in this instance, the spouse was nominated and the patient's mother had made numerous attempts to obtain information regarding her son's condition from the medical team managing the patient due to the grievance that she was not being kept informed on his condition by the patient's spouse. I'm sure we all know the mother-in-law, daughter-in-law conflicts. So the medical team sought permission from the patient's spouse in compliance with, we all know that the POPI Act is in place, to counsel the patient's mother on his poor prognosis and low chances of survival. And what did the spouse do? As predicted, she declined. So due to her refusal to consent, the medical team disclosing information to the patient's mother regarding the son's poor prognosis resulted in medical ethicists being instructed to advise and steer the process of law to achieve ethical resolutions in the best interest of the patient. Now, we note that it is not straightforward decision-making for a medical practitioner with the introduction of the POPI Act. So they usually get an ethicist for these kinds of scenarios. And what did we do? We advised as follows. We directed the doctor to attach and place on record in the patient's hospital file that the mother of the patient left myriad messages in the medical ICU with nursing staff for the doctor to contact her regarding the fact that her child was in extremis. So we advised the doctors and the medical team that to deal with issues of guardian refusal for the doctor to interact and update the patient's parents regarding his condition, it is morally and ethically incorrect for a guardian to prevent a patient's parent from being informed of his condition, especially where the prognosis of their child is poor. So this will not apply if the patient had himself told the medical team that he does not want the doctor to have any interaction with his parents. And this patient came in comatose, so it was clearly not the case in this instance. So we went on to further advise the medical team that if doctors were to communicate with a patient's parent, irrespective of the fact that the spouse is the guardian, their communication will be regarded as privileged and protected from any action by the guardian. This is where it's called a qualified privilege. So a qualified privilege exists where a person has a moral, legal, or social duty to communicate information to another person who now has a reciprocal duty to receive that information. Then we went on to advise the medical team that the legal convictions of the community would deprecate upon acts of disregard towards a mother's plea to be unapprised of the condition of a child's health as per her rights. Hence, it was duteous of the doctor to respond to the requests of the patient's parents in terms of his moral, legal, and ethical duty via the doctrine of privilege. And this is tried practice internationally. So going on to another scenario, which is my final scenario in this instance. So this is something that I know is going to be a little bit difficult to comprehend, but I chose this example because just to emphasize that the medical ethicist is not just restricted to knowing medicine itself, but they also have to know other aspects such as autopsies, pharmacology. And in this instance, the reason why I'd like to share this with you guys is because this is something that we made a breakthrough in. So in this instance, we were basically called in thinking it was a normal instance of where we saw a patient who was a 38-year-old patient admitted into ICU, critically ill, and had septicemia. So in this instance, a generic antibiotic, and I'm sure everyone knows that we are all told that the generic antibiotic is exactly the same as the original antibiotic. So the generic antibiotic was administered to the patient as opposed to the innovator. We call it the innovator, but that means the original antibiotic, as per the recommendation of the hospital groups, as everyone is aware that generics are supposed to be identical to the innovator. And the reason that it's promoted is more especially because it is cheaper. So despite the administration of the generic antibiotic, the patient's response was alarmingly poor, and the patient showed progressive clinical and biochemical deterioration whilst she was on the generic antibiotic. This created both medical and ethical dilemmas, and therefore the doctors sought advice of medical ethicists. In this respect, it was so interesting. And in this respect, what we did was we went on to advise that it is very important to understand that the patient has had a greater chance of survival on an innovator antibiotic than she has on the generic antibiotic. So the medical team have a duty to administer the innovator by virtue of the requisite ethical requirements to provide optimal treatment. Hence, we assisted in changing the patient's treatment plan from the generic antibiotics to the innovator antibiotics. And upon administration of the innovator antibiotic, the patient began making a remarkable recovery. Our priority is to help patients recover and keep mortality rates low. Therefore, this becomes precedent for recommendations to other medical practitioners in the future, as it could help to save more lives, as everyone deserves a chance to live. So the ethical principles of what I spoke about earlier, non-maleficence, beneficence, and justice applied to reach a resolution of optimal treatment of the patient and to give her a chance to live. Now, how did we justify this? This is the difficult part, right? So we affirm that we are in favor of generic antibiotics that have the same chemical composition as the innovator. However, we made a breakthrough in advising that sometimes there are superficial components that classify the generic and the innovator as identical, but that's not always the case, as there are factors that many are not aware of. So we made discoveries in this regard. As I've mentioned, medical ethicists have a duty to have detailed knowledge of pharmacology, as well as we educated many entities on this. So I'm so excited to share this with you all. So we found that there was an awareness was raised via various studies conducted on the innovator medication and the generic medication. So what is called a comparison study, where we learned that all drugs have something what is called an active pharmaceutical ingredient, right? So this is where the active pharmaceutical ingredient of the generic medication falls within what is called an expected range of potency, concentration, and serum pharmacokinetics as the innovator, which is the original drug. So based on these aspects, the generic drug is labeled as what is called interchangeable and bioequivalent, meaning it's supposed to be the same as the innovator antibiotic. That is where there's efficacy and safety are assumed without direct proof. So this policy on generic drugs is accepted and implemented worldwide, yet it has one critical drawback. That is, there's experimental evidence that we found that bioequivalent generic drugs can be inferior with respect to the original or the innovator if there's therapeutic non-equivalent, which means how it responds within the patient's body, which conveys clinical and microbiological failure, increased mortality, and bacterial resistance. So the difference between the innovator and the approved generics is sometimes merely what is called a structural difference, and which is very difficult to detect. It is innocent in appearance and totally accepted under regulations, which seems to be responsible for failure of the generic medication. This is where we see patients and we wonder why patients are deteriorating, yet they're on the best drugs. However, sometimes the generic drug within the body, the patient is not responding to it due to therapeutic non-equivalence. So it is pivotal to judge a product not based on specifically bioequivalence, which is what all drugs are passed on. Rather, it is important to judge a drug based on therapeutic non-equivalence to reach positive patient outcome, since bioequivalent generics can fail in ways so inconspicuous that they pass undetected under current regulations. So this is one of the most interesting cases that we had to deal with, and we advise medical practitioners, hospitals, and there's a lot of institutions that are still learning on this. So I'm really glad that I got to share this with you guys. Thank you.
Well, Ravana, that's most interesting. To be honest, personally, based on the scenarios that you've actually provided, on our side, we don't ever think that there are so many different considerations that you have to take into account when rendering that advice, because if anything, I think you're there to be the support and actually push for the best possible outcome. So I do know that we're now going to touch on what may seem to be a very controversial scenario, and that would be something relating to religion. So Ravana, sorry, back to you.
Thank you, Nadia. So with regards to religion, right? So what we're going to do is this is like a mouthful. So I have so much to say here because there is so much that people don't know with regards to advanced directives, as we are all just taught that an advanced directive of a patient must be respected. But I'm going to take you through my life scenarios of my life in practice where that is not the case and where these scenarios are limited. So in speaking of that, we're going to touch on religion, right? So religion is increasingly significant in healthcare, and it's an important task for medical practitioners to ensure that the religion of a patient is treated with the same ethical seriousness as every other ethical relationship. So we shall discuss the right to religion versus the right to life, advanced directives, and so forth by utilizing the widely known precedent of, I'm sure everyone is familiar with, the Jehovah's Witness. As we all know that the Jehovah's Witness and their refusal to blood transfusions, which is applicable to all other religious beliefs as well. So what I'm going to say here is applicable to everything related to the right of religion in healthcare. So generally, we all know that the Jehovah's Witness religion has created massive medico-legal dilemmas due to their known refusal to receive blood transfusions from others, where they will not even accept their own blood as well. So the Jehovah's Witness is against all forms of blood transfusions, and this is the start of a medico-legal conundrum because times and mindsets are basically metamorphosizing, which means that people are not following religious norms mindlessly. There are many Jehovah's Witnesses that we've seen in practice that don't approve of this in respect of their religion, with knowledge that they may die without a blood transfusion. Therefore, they may approve blood transfusions. So a medical practitioner must not assume that this is a blanket provision in respect of transfusions and refuse to transfuse all Jehovah's Witness patients. So what is the legal position in this regard? In this instance, the medical practitioner must provide mandatory counseling to a Jehovah's Witness patient, or any patient for that matter, that has religious conflict with healthcare, and give them the freedom of choice in respect of blood transfusions. And this is known as the ethical principle that we apply, which is autonomy. And this autonomy is entrenched in the South African Constitution that provides patients' rights to bodily integrity and autonomy. This means that if the Jehovah's Witness is providing their own consent, then he or she has a right in terms of the Constitution of South Africa to refuse a blood transfusion that could save their life. So that is entrenched in Section 15 of the Constitution, which is the freedom of religion, belief, and opinion. So what does this mean? This means that people belonging to a religious group cannot be denied their rights to practice their religion, provided that their religious beliefs are not exercised in a manner that is inconsistent with the Constitution of South Africa. However, we also question the right to life, which is entrenched in the South African Constitution, whereby we have Section 11, which is the right to life. So in this instance in relation to the right to life, this human right is not absolute and subject to limitation, which will be explained shortly. Therefore, the medical professional has a duty to uphold patients' autonomy, even over their constitutional right to life in respect of a DNR, or a decision by the patient to refuse blood transfusion, even at the expense of his or her own life. So now we go on to the right to life versus patient autonomy. Now we're versing legal versus medical ethics. So the principle of autonomy is codified in the International Bill of Rights, the African Charter, the South African Constitution, the Patients' Rights Charter. And the reason for patient autonomy is the common notion to protect the patient's liberty, their privacy, and integrity. So autonomy is the manifestation of one's legal and mental capacity to understand and make informed decisions. Section 12 of the Constitution emphasizes that everyone has the right to bodily and psychological integrity to make their own decisions on reproduction in respect of security and control of their body, and not to be subject to medical experiments without their informed consent. Now we have the HBCSA guidelines, right, which provides us with ethical standards and values, and they impose ethical duties on medical professionals. For example, respect for patient autonomy. This is where the guidelines of the HBCSA directs that if a Jehovah's Witness has given an advance directive and they were in sound and sober senses to not receive a blood transfusion, then such refusal has to be accepted on condition that the decision in the advance directive is clearly applicable to the patient's present circumstances, or that there is no reason to believe that the patient has changed their mind. So in South Africa, it is unethical for a doctor to refuse to treat a patient just because the patient has a religious belief that is not in compliance with healthcare. So further, if the patient is in a current doctor-patient relationship, meaning that the doctor is providing ongoing treatment to the patient, that practitioner cannot breach that doctor-patient relationship, as this will constitute a breach of contract, and he has to continue to treat the patient with the limitation of blood transfusions to the patient. The medical practitioner also has to explore other treatment options that could be administered to the patient in order to divert from using blood transfusions. As we have noted, that the Patient's Right Charter promotes autonomy and informed consent. However, we have the Bill of Rights, and in the Bill of Rights, there are checks and balances in applying the law. So now we arrive at my question, which is, can a patient's autonomy be limited on the, now these are ethical aspects, and the answer is yes. Patient autonomy may be infringed to promote public health, where a South African court or law may limit autonomy if it's in the best interest of the public or the patient. Therefore, autonomy can be limited if legally required and duly justified. And how does this happen? So we have Section 36 of the Constitution, which is the limitations clause, and human rights enshrined in the Bill of Rights, which is in Chapter 2 of the Bill of Rights, are not absolute. So they can be limited in terms of Section 36. So in application of Section 36, I'm going to give you scenarios where we can use Section 36 and we can limit patient autonomy via advanced directives. So in the first instance, what does the medical practitioner do if the patient has an advance directive and is unable to consent or refuse medical treatment? So in this respect of an advance directive, it is very important to scrutinize the advance directive and focus on the time that it was executed. Remember, people's minds change all the time and according to circumstances, yet they neglect to amend their last wills and testaments as well as their advance directives accordingly. Therefore, our advice to medical practitioners in this regard are that in the event of a patient having an existing advance directive and is unable to consent or refuse medical treatment, it is advisable to discuss it with a proxy, such as the spouse, as they would be in a favorable position to advise on the updated state of mind of the patient in respect of that advance directive. If the spouse creates vacillation on advance directives of the patient and instructs the doctor to transfuse the patient with blood to save the patient's life, then the doctor should not refuse to transfuse that patient purely on the existence of that advance directive. The protocol is to approach the court for a legal order to retract that patient's advance directive if the patient does not have the capacity to make their own decisions. Because we need to keep in mind that death is irreversible. So it's very important not to just specifically go on what's on paper, because people's minds change all the time. Then we get onto the scenario where what happens if a patient is against blood transfusions for religious reasons, is unable to consent, and now does not have an advance directive? So this is where we have the National Health Act, which makes provision for this and states that in such a case where a person has been mandated by a patient in writing to consent or refuse blood transfusions on the patient's behalf, this means that a proxy consent or refusal to transfuse should be obtained from the patient's spouse or partner. If there is no spouse or partner, then it will be obtained from like a parent, a grandparent, an adult child, a brother or a sister. And it is very strict that it must be done in that order. So if the next of kin decides against a blood transfusion to the patient due to religious beliefs, and if the medical practitioner is suspicious of the decision of the next of kin, despite the fact that the incapacitated patient is a Jehovah's Witness and also against blood transfusions, then they need to look at Section 36 of the Constitution and limit the right of the next of kin's autonomy. If the medical practitioner is suspicious and they are of the opinion that the next of kin is making this decision without proper informed consent, such as in haste, a lack of professional information, under duress or fear of religion, and not out of their own free will, so they're not making a rational decision, then the doctor has the duty to approach the High Court in respect of requesting an order to allow the doctor to perform interventions such as transfusions to save the patient's life. So that is in terms of the right to life now will outweigh the patient autonomy on the basis of sound factual reasoning, as human rights, as I mentioned in the Bill of Rights, is not absolute. So every patient's case and decision in respect of autonomy will be different. So if the medical practitioner is highly skilled and equipped to reach these resolutions with the patient and doctor efficiently in compliance with the law in the best interest of all parties, where such experts direct doctors and to reach resolutions as amicably as possible. Now, getting down to the next scenario, which deals with what occurs if there is a medical emergency and the patient will die, and now there's no time to even obtain a court order. What do you do in this instance? And this is not just for ethicists, this is for any person that is in that predicament with respect to your families or your friends or loved ones. So the right to emergency medical treatment opens a new door of explanation in respect of the right to life and patient autonomy, which is very interesting if the patient goes into a state of emergency and refuses blood transfusions. So the doctor has a duty in terms of Section 27(3) of the Constitution, which is the right to emergency medical treatment, to treat the patient within the boundaries of not transfusing that patient if that patient is awake and refuses the transfusion. However, the medical practitioner should still counsel the patient in those circumstances on the necessity of a transfusion to save their life. However, in an emergency situation, if there is a patient that is against blood transfusions or is a Jehovah's Witness, they arrive in trauma, unconscious, and there is no time to locate and obtain consent from a next of kin as emergency medical treatment is required, then the requisite informed consent is now outweighed against the delayed treatment. What does this mean? This means that Section 36 will become applicable and it will override the autonomy of the patient in an emergency to save that patient's life, and it will be highly justifiable by the medical practitioner. Where the medical practitioner can show under the circumstances that the patient was unconscious and that it was in the best interest of the patient to administer emergency medical treatment under the doctrine of necessity, because as I mentioned, death is irreversible. So this means that it must be exhibited that under those circumstances, a reasonable person would consent. Thus, the probabilities are that the patient would consent. So the medical practitioner can justify this under the state of emergency. It is impossible to know whether the patient's preference wishes are still reflected in the patient's present views. Now I'm going to add something a little more interesting, and again, a first, as this is not even stated in law. So let's add an interesting twist to this discussion. What occurs if the doctor himself refuses to administer blood transfusion because he is against it? What do you do in this instance? Now, this is very interesting because there is no South African or international law that governs this point. So it is answered by using general law principles. So doctors may practice their religious beliefs, and their religious beliefs will be respected in terms of blood transfusions if there are other medical practitioners to transfuse their patients. But in the case of emergency, this is not applicable, as in terms of emergencies, they cannot use their religious beliefs as the reason to refuse to administer transfusions to patients. So doctors whose religious beliefs are against blood transfusions must still be trained to transfuse patients, as they will be constitutionally required to do so in the case of emergencies under Section 27(3) if there are no one else available to transfuse patients. Now, what have we noted from all of this? We have noted that the common factor in all instances is that the right to religion is limited in terms of Section 36 of the Constitution, where balancing of rights is done in all of the aforesaid instances. We note that the right to religion can be limited via the balancing of the right to life, which outweighs the right to religion in specific circumstances, as we've discussed. And now I'm going to move on to blood transfusions in children. And it's very important for us to understand that the position in children is extremely different from that of adults. So the legal position of the right to refuse medical treatment is different for children, where we have something called the Children's Rights, the Children's Act. And in terms of the Children's Act, to medical treatment. So this has specifically outlawed refusal by parents or guardians to consent to medical treatment solely on religious grounds, as the High Court of South Africa is the higher guardian of all children and has the power to invalidate the parent or guardian's consent. There is a very important case that serves as the landmark judgment that is applicable to all in healthcare, which is the case of Hay versus B, where a pediatrician approached the court to override the parents who refused to transfuse their baby with blood based on religious beliefs. And it was very interesting in terms of the way the court ruled in this judgment, where the court went on to state that the Constitution dictates that, yes, a child's best interest is paramount. The court also went on to state that the child's basic right to life is a basic constitutional value, and the baby's right to life could not be violated. They further went on to state that in weighing out the right to religion versus the right to life, the court held that it acknowledges that the right to religion must be respected together with their concerns, but it was not reasonable and justifiable enough to override the baby's right to life and just to allow the baby to die based on such a belief. And the interest of the baby to receive such blood transfusions outweighed the reasons of the parents. So the court went on to state that withholding consent to a blood transfusion solely on religious reasons should be regarded by doctors as unlawful. And in such instances, the common law rules of emergency medical treatment becomes highly applicable. So this means that the common law states that in emergency situations, medical treatment must be given without consent of the patient or persons legally competent to give consent on behalf of the patient or such other persons. However, if the refusal to consent to a medical treatment during a medical emergency is unlawful, such as refusal to give blood transfusions to a minor based on religious grounds, then the doctor should refuse to comply and proceed with treatment. The conduct of doctors will not be classified as a violation, as the refusal to consent to a blood transfusion in emergencies to save a child's life or prevent injury or disability to that child is in itself unlawful. And such unlawful refusal to consent to those transfusions to save that child's life in an emergency is regarded as against public policy and is highly unconstitutional. So I'm just going to put up a few recommendations, and I'm going to run through it very quickly due to time constraints. So in this instance, there are recommendations to medical practitioners. And in this instance, medical practitioners, if parents or guardians refuse to consent to blood transfusions of a minor in cases of emergency, the doctors have a duty, yes, to counsel the patients on the unlawfulness of their refusal to consent to save their child's life from disability or death. However, the doctors must advise that they do respect all religious beliefs, but ethically they have a duty to save lives and to prevent harm to a child. So they must inform the patient that they will still go ahead and administer treatment to save their child's life. The doctors must also advise patients that patients have a right to approach the court to stop doctors from administering life-saving treatment on their child. And they also have a duty to go on to state that, to inform the parents that in event they do approach the court, they are going to be highly unsuccessful in this instance, as the court is the upper guardian of all children. So doctors must inform patients that they have provided informed consent, informed counseling, and that their actions to administer blood transfusions is extremely lawful in terms of the law. So despite the human rights of parents to dignity, privacy, and freedom of conscience and religion are valid, the High Court of South Africa has held that such rights are superseded by a child's right to life in the case where a child's right to life is at risk. Thank you, Nadia.
Well, thank you for that, Ravana. One would think that religion is such a massive right, but when you do think about it, it is something that can actually be limited. So just in closing, and my last question to you is, what relief does a medical ethicist provide to a healthcare professional, and what lies ahead for the medical ethicist?
So the medical ethicist is paramount in this day and age because plentitude of world religions teaches us ethical conduct, such as these are accepted as universal moral norms. Just to mention a few that we all are familiar with: do not kill, do not steal. So such ethical codes are recognized by most people undisputedly. However, they are unfortunately they are not unfortunately encompassing enough pertaining to the world of medicine. So in the past, it was unquestionable that being of moral character is adequate framework for healthcare, for the healthcare professional, to comprehend his actions in his decisions. In a world that has revolutionized to a digital era, where patients have cyber access to the most intricate medical information on their devices, alludes to the fact that moral character is no longer sufficient. So this signifies that the medical ethicist will now be a constituent of the daily life of the totality of healthcare workers through their specialized system of medical ethics to assist healthcare workers to reach informed decisions and to confront the complex dilemmas in medicine successfully. To evidence the importance of the medical ethicist futuristically, we view their role at present in the greatest pandemic of our lives, where imperativeness of a medical ethicist was evidenced during the COVID-19 pandemic. I am living proof of that. So in a plethora of patients who were critically ill with poor prognoses due to COVID-19, provoked patients and families to speculate that doctors did not treat patients supremely, as it is medically known that only 2% of COVID-19 patients recovered from ventilation prior to vaccinations. And I'm sure everyone is familiar with this. Accordingly, families of patients that demise were of the belief that it was imputable to medical malpractice. However, many deaths were due to poor prognoses, resulted from late admissions to hospital or the scarcity of resources, for example, limited ventilators due to mass infections, which did not constitute medical malpractice. Rather, it was a constitutional limitation. So in this context, when medical ethicists are instructed to join the medical team in respect of patient management, they are capable of illustrating to the patient's family that legal and ethical doctrines were adhered to. This verifies to the patient that there was no legitimacy to medical malpractice. Contrarily, if we remove the medical ethicists and we extract them from this equation, the family's thoughts actually maneuver towards medical malpractice, as they are of the belief that the doctor did not practice medical ethics by allowing their loved ones to demise. That is, people act unmindfully out of hysteria, which we don't blame them for. So COVID-19 was the greatest test of our lives to prove the essentiality of the medical ethicists who supported medical practitioners and healthcare institutions in a pandemic setting. From the beginning of time, the foundation of medical practice is medical ethics. Therefore, from a hospital manager to an administrator, a nurse, a doctor, will all have an obligation to proficiency in legal and ethical responsibilities, which has to be marshaled by a medical ethicist in the present and futuristically to provide the relief of autonomy amongst healthcare practitioners to deliver impeccable service in healthcare. So there is an increase in demand from what I have seen for ethics committees, which should be implemented with specialist medical ethics practitioners presiding to deal with daily dilemmas that may arise from patients, families, and healthcare. And the medical ethicist is going to eventually become mandatory in healthcare institutions, medical malpractice insurers, and medical malpractice companies, as the workings of such a practitioner is so unique that their practical clinical exposures to their ethical duties that they actually have an eye to reach solutions rapidly. In my personal opinion, the medical ethicists are going to be the white blood cells, the medical profession. So every day I am proof of the fact that the demand for the medical ethicist is becoming paramount in respect of a successful healthcare system, not just in South Africa, but globally, where my ethical experience was utilized by an international news network in respect of medical legal dilemmas. So our extreme application of philosophy brings me to a very potent close, where I would like to share an aphorism that is very personal to my practice. And such an aphorism is "Civis pacem parabellum," which means let him who desires peace prepare for war. We stand by our philosophy that we shall fight to restore ethics and righteousness in the healthcare fraternity in the challenging years ahead, Therefore, the future of optimal healthcare starts with the medical ethicist. I am really quite excited to witness the future of the practice of medicine reach optimization and advancement via a revolution of medical ethicists in South Africa. And I'm sure that we will touch on each of your lives in the profession as well as the lives of your loved ones. Thank you very much.
Well, thank you so much for that, Ravana. It's been a very, very informative session. I do see in the chat that we do have a question from our very own Kamini Shanmugam. How easy is it to get a court order setting aside the advance directive? And what do you do if it's an emergency and not enough time to obtain the court order?
So firstly, a court order can be obtained on a matter of emergency. So it can be obtained absolutely within, I would say, you can do it in hours. Depending on the urgency of the matter. But as I explained on one of my scenarios, basically with regards to an advance directive, if it is a state of emergency, then Section 27(3) of the Constitution kicks in and you can actually override patient autonomy. So it's going to depend on whether the patient is awake and conscious. If the patient is awake and conscious and the patient refuses emergency medical treatment, or refuses specific forms of treatment, then the doctor cannot override that. But if the patient is unconscious, then Section 27(3) kicks in and the doctor is allowed to override that, provided that the doctor has reasonable justification to show that they could convince the patient otherwise, or the doctor, as I mentioned on numerous occasions in my talk, that death is irreversible. So the court is very lenient in that respect. So a doctor can override patient autonomy in that instance.
Okay, thank you for that. And then we have got a question from Jadut Ramsinder. Any comments on a living will?
Yes. So the living will is basically my baby. At one time, there was a time where people never made wills in general, and people would die and they would say, so what happens in this instance? So a living will, just as wills used to be bizarre, a living will is also considered as bizarre in this day and age. But I'm noticing from practice recently, when we go in for patient counseling and we explain the living will to them, it is so popular. So people want their last wishes, just as you want your last wishes in terms of your material aspects and your property and all of that to be complied with according to your wishes. People now want their bodily compliance to be adhered to in terms of what happens to you at the end. There are a lot of patients I've noticed after COVID-19, there's an increase in cancers that we are seeing in hospitals. There's an increase in a lot of these comorbidities. So in those instances, there are patients that are critically ill that want to refuse treatment as they do not want to prolong suffering. So that is when they come in with the living wills. And we've been actually quite busy in that respect. So the living will is extremely popular in this day and age. And it's something that I personally would advise people to make, because you need to keep in mind that a living will is not necessarily an order to direct your death. A living will can also be made where, okay, come on, let's go on to reality. There's a lot of people that are abandoned by their children. And in those instances, children may make orders to state that, go ahead, remove ventilation of a parent, but a parent may not be of that wish. So a living will can also be changed and we can reverse it. I personally made those kind of wills where we've stated, do not remove ventilation. So it is so interesting, as you practice, that you can actually do different things in respect of directives.
Well, thank you for that, Ravana. This does bring us to the end of the session as we have run out of time. Thank you for joining us. And just everybody on the call, thank you so much for joining us. Thank you for your support. Wishing you all a wonderful, wonderful Valentine's Day. And just to keep an eye out, guys, Cyber Thursday is happening. So please do join us then. So have a good one, guys. Take care.
Thank you so much. And thank you everyone for joining my session. I really appreciate it and it was wonderful.
Thank you guys. Stop.